There's probably a golden lecture moment in your life. Kids 10 to 11. That's maybe it. So this doesn't look like 60 people. Here we go. So we're going to talk about diseases of the liver. We talked about liver function tests. So it starts with cholestasis. Should be like kind of where we left off yesterday. So cholestasis, we played with a couple different times. This is the impairment of the bile. And it's also called obstructive jaundice. You can call it whatever you want. And it has intra and extrahepatic. Extrahepatic is hands down way more common than intrahepatic. And I think by now you guys should know what are the three biggies that cause extrahepatic cholestasis.
Cancer of the head and pancreas.
Cancer of the head and pancreas, yep.
Gallstones.
Spasm and stone or stricture of the common bile. Those are the biggies. And you can see in your notes there's lots of words there, but truly those are the big shots that you kind of want to focus on. So clinically, it makes most sense to kind of think these symptoms through. So jaundice, duh, that's what we're talking about, right? So if you can't excrete bilirubin through bile, it can go up in the bloodstream, people are going to be jaundiced. Hyperbilirubinemia, so that means increased bilirubin in the serum. So take a shot, or it's 8:02 in your day today.
Conjugated.
Conjugated, very good. Direct or indirect?
Direct.
Water
Soluble.
Perfect. So we go to the next one, dark urine. How come?
It's in the urine.
Because there's bilirubin. So you can memorize lists of symptoms, or you can figure out how come that patient has to have that. So the dark urine is from the bilirubin. Pale stools, want to take a shot at that one?
No urine.
Yep.
Are low.
So you can't get bilirubin through to get turned into urobilinogen to get turned into cytoplasmin. So the patient is going to have pale stools. Combination of dark urine and pale stools, pretty classic obstructive jaundice. Intensive pruritus, the deal there is that you have excess circulating bile salts because you can't get rid of them through the common bile duct, and they're very pruritic, so it causes people to have pruritus or tissue. Steatorrhea. Steatorrhea is the presence of too much fat in your stools. And the deal there is you need bile to absorb fat. If you don't have bile because of the obstruction, you can't absorb fat, you have excess fat in the feces, you're going to steatorrhea. Elevated prothrombin time, the deal there is the vitamin K show. So it's the same thing. Vitamin K is fat soluble. You need bile to absorb fat. So when you're not getting bile through, you're not going to absorb fat soluble vitamins. You need vitamin K to make prothrombin. If you don't have vitamin K, you can't make prothrombin. If you can't make prothrombin, you don't get to make thrombin. You're going to get to clot. So there's the clinicals. The lab should not be like surprising. I don't want to, what? GGT is elevated? So, or you can, but then I may call you on it. So here we go. High alkaline phosphatase, because we're talking about cholestasis, and that's a good enzyme for cholestasis, right? So alkaline phosphatase, generally it's going to be more than 3 times the upper limit of normal. It's going to be decently elevated for you. GGT would be increased, and it would parallel the alkaline phosphatase, because that's what they do in cholestasis, they parallel. So if alkaline phosphatase is 3 times the upper limit of normal, so is GGT. Makes sense. Then it's high serum cholesterol. Do I need to say acute and chronic in numbers and stuff, or do you want to write it down for completeness? Right. So if it's acute obstruction,
3 to
what happens
400.
cholesterol, 3 to 400 milligrams per deciliter, and if it's chronic obstruction, 7 or 8 milligrams per deciliter. And as important as those numbers are, is like again for a patient who has a cholesterol of 800, it's inappropriate to talk to them about fish oils and exercise and red wine and oatmeal and stuff like that. You're in a completely different area of your brain. Then some words that might irritate you, but direct serum bilirubin is increased. Direct is conjugated, right? So we would expect direct to be increased. Total serum bilirubin, if a direct or an indirect is increased, total just is increased. So it makes it kind of easy. So the total is gonna be increased. Quickie question, would the serum bilirubin be present in the urine or not?
It's serum, so no.
Direct, yes. So if you have an increase in direct in the serum, that's water soluble, we would expect bilirubin to be found in the urine. That might not actually be in your notes, but the urine bilirubin would be increased. Intrahepatic obstruction is usually due to things like malignancy, some drugs, stuff like that. Not as a big a deal as the big three there. Extrahepatic, the last little point there. So I mentioned yesterday, we're going to go with a 2-to-1 kind of ratio with conjugated to unconjugated. Just know, and this is what that point says, is that eventually that conjugated stuff unconjugates itself. You get a ratio that's more like 1-to-1. I don't want to make it that hard. I want you to just think there's more of the conjugated stuff. It's easier as pathology in the brain. Think of it more like a 2-to-1 ratio. And lastly, the transaminases, this is not their job to go up in this disease. So your transaminases, if they're increased at all, it would be little, teeny tiny, minimally increased, right? Treatment is generally surgical or extrahepatic. They have to remove the stone, they have to cut out the cancer, stuff like that. Intrahepatic would be cause-related, so if it's due to a drug, they're taking out that certain drug. If it's due to malignancy, then deal with malignancy. Vitamins A, D, E, and K are supplemented because of the fat-soluble nature and the fact that they've had trouble absorbing fat. So those should be supplemented.
Would that be done, I mean, if they still can't absorb them, what kind of testing do?
It would be after. It would be after. It's a good question. So the supplementation would be after you remove the obstruction. It's kind of like, I had an analogy that left me really cut out. Yogurt. It's kind of like yogurt and infections. If you're taking antibiotics. So when you take antibiotics, they're largely specific at what they want to go after, but they have some collateral damage, right? And then they take some of the good guys with them. So it doesn't make a whole lot of sense to be eating yogurt and probiotics while you're taking those antibiotics because the antibiotics are just going to kill those guys off. It's bad bang for buck. But what makes a lot of sense is after you're done with your course of antibiotics, get the good guys back and get some probiotics. Take yogurt or something like that. That makes sense to recolonize you guys. So kind of the same situation. Okay. Good question. All right. Hepatitis, here we come. So the timing, I guess it could be better, but it could be way worse to talk about hepatitis. It's a little bit crunchy. Here we go. Hepatitis, we're going to talk about viral hepatitis. There's lots of hepatitis. Okay. Viral hepatitis is specifically caused by at least 5 viruses, A, B, C, D, E. They've got a couple more. I'm not going to talk about anything about A and B. That's just what I want to talk about. And C is actually really important. But we're just going to do A and B. So we're going to start with A because it's a little easier. Type A viral hepatitis is spread by the infamous fecal-oral route. So this is people who don't wash their hands and prepare food. Places that use human feces, that sounds odd, but human feces as fertilizer, and it gets into the lettuce or the whatever crop you're growing. Then you're getting, that's how you get it, okay? Or little kids that may be allergic to wipe their butts and then put their fingers in their mouth. That's how you get viral hepatitis A, okay? The incubation is super typical for any virus. It's about 2 to 6 weeks or so, okay? The hepatitises are largely characterized by 3 phases of symptoms with some exceptions. Type A is pretty classic in that you get a prodrome phase. The prodrome phase for the patient can feel like crap. I'm sure a teacher doesn't want to say that out loud, but they really feel just horrid. They have the classic anorexia, malaise, fatigue, stuff like that, but big, just big. I have cases to do for you. Probably the last one we do was a student of mine. He said, you use this case in class, it's good. He said, I want you to tell them how bad I felt. I said, I'll be prodromal phase is called the icteric phase, and this icteric would be yellow or jaundice. In the icteric phase, if a person develops the symptoms of an icteric phase, then you get the dark red, you get the jaundice, starts in your eyes, goes down to your feet, stuff like that. The majority of patients don't develop jaundice. For type A viral hepatitis, it's not as big of a deal from a public health point of view. Type B is a big deal. So about a quarter of them actually turn yellow for you. It can be confusing for diagnosis because if somebody is jaundice, then you say, aha, must be something wrong with your liver. If somebody just has profound fatigue and anorexia, they're throwing up, they don't like to taste cigarettes anymore. Sounds a lot actually like early pregnancy. It can be confusing to figure out what's going on. And the last thing is, if they make it all the way through those two phases, is the recovery phase. They just get better. So their symptoms go away. If they had jaundice, the jaundice slowly fades over about a month or so. All of their labs start going back down to where they should be. And that's called the recovery phase. So most people with jaundice go through those three phases pretty nicely. Forgot to mention in the second phase, the icteric phase, even if they don't turn yellow, they feel better. When you go from I feel like I want to die phase to feel a little bit better. That's characteristic of the icteric phase, and they feel better. They might turn yellow, they might not. So lab-wise, we got two kind of chunks for lab here, kind of your classic labs and then some serological findings. So AST and ALT are elevated super high. When you have hepatitis, your transaminases go up 10 to 20 times, if not more, the upper limit of normal. So if the normal range is something like 0 to 40, 0 to 50, people with hepatitis will have 1,000, 2,000, 3,000, things like that. Which one goes up higher, AST or ALT?
ALT.
Is that an L? Say no. Yes, so ALT is characteristically higher than AST. It's classic, okay? Increase urine bilirubin. So just those are three words in your notes. But this is the middle picture of those diagrams that we did. The one that is really challenging to figure out what all those arrows are doing. That's this one. That's hepatitis. So the bilirubin goes up. The only time bilirubin can go up in urine is if you have an increase in direct. And people with hepatitis have direct and indirect. A little bit more indirect than direct. Should go in order of my notes here. Total serum bilirubin goes up. Oh, I just said that. So the direct goes up, the indirect, we're giving it 2 arrows. We're going to go 1 arrow with direct and 2 arrows with indirect. And then obviously the total. Alkaline phosphatase, GGT, if they go up, they're going to go up TD. That's your question. So, and thank you for doing this. Oh, public health. My favorite thing in the world, that's not true, my favorite thing in the world is probably an 18-month-old person. I think they're my favorite human beings in the world. But really, here is coming to work at 6:10 and learning. And so today's learning was the World Health Organization. Today is World Polio Day, and they have declared today as they wiped out number 3. So the wild polio virus type 2 strain gone. Did that one quite a few years ago, and the type 3 wild polio has been declared eradicated from the face of the world. And the number 1 strain is left in 2 small places in the world, Pakistan and Afghanistan. And they're working on that, so it's kind of yay. You guys are too young to remember polio, aren't you? You are. Maybe you have a grandpa or something. Bad, very scary time. Polio was a very scary time on this planet. Why did I start about that?
Learning.
You sneeze. Oh, public health. Thank you, Parker. Thank you. Public health. So you're supposed to sneeze into your elbow, right? And there's a lot of people that don't. And they just sneeze out there, and you could probably Google this to watch a sneeze in slow-mo. It's pretty cool. Or even there's I think there's one out there that simply say F. Just saying F on a stuff that comes out of you is just like, we should all wear body condoms. Two things I probably shouldn't have said in the span of 16 minutes. Wash your hands, wash your hands, wash your hands, wash your hands. Okay, back to this stuff. I did alpha phosphatase. This is a virus, and we just talked about this very quickly yesterday. I talked about it ad nauseum. A virus is going to cause a decrease in your white count and an increase in your lymphocytes. Right? So if you did a CBC, that's what you would expect to see. You're a neurobilinogen, just trust me, we did this. That's the really weird thing about this particular picture is how come that gets there. You have it written down, you have words on it. Trust me, it's increased. So those are kind of the easy ones. Those are good tests. The best tests are going to be serology and measuring some antibodies. So there's always two like major groups. There's going to be IgG and IgM. And which one do you want to order if it's an acute hepatitis A infection? Correct. No. And if this is a person who says, I think I had hepatitis like 20 years ago in college, but I don't remember, you want to pull out IgG. That's what your notes say, okay? So if you look at a little bit more specifically interpreting your serological testing for hepatitis A, if the IgM antibody is elevated but IgG is not, that means you have an acute infection. It takes a little time for that IgG to get going there. If the IgM antibody is not detected and the IgG is increased, it could mean it's an old infection, or it could mean it's a recent infection in the convalescent stage. So the IgG went away and the patient is developing lifelong immunity to hepatitis A. That was pretty easy. Yeah, prognosis for Hep A is it's resolved spontaneously, all by itself. That brings us to Hep B. Unless there's any questions on that. Hep B, personal opinion. If it wasn't for HIV, I think hepatitis B would have way better press. There would be ribbons, there would be days, there would be stuff. Hep B is ugly. It's just an ugly virus. There's no way to get around it. Highly infectious. Has a decent mortality rate. Is bad. So in the United States, about 400 healthcare workers would be infected badly with Hep B and have to kill. When I was at the University of Minnesota, we had a tech die of Hep B. This is bad stuff. When I see you guys flinging needles around, I'm worried for Hep B. Not HIV so much, although it's there. Hepatitis B is ugly. This feels like a public health thing. So if I was evil and I'm not, but if I was, who comes after me? A teacher comes after me. We have we don't know. Well, let's say there's a teacher that comes after me. I could take some hepatitis B infected serum and smear it on here. Someone would have to touch it, okay? Highly infectious for 14 hours. That's a bad virus. It's a bad virus. You can take 1 tablespoon of blood that is hepatitis B infected. Not a lot of blood, 1 tablespoon. Dilute it in a railroad car of saline. It's quite a dilution factor. It's highly infectious. This is ugly stuff. Ugly stuff. Okay. Here we go with the ugly stuff. It is transmitted 2 ways. Through needles and through sexual intercourse. That's it. Okay. The incubation is remarkably long for a virus. Viruses are like 2 to 6 weeks. 6 to 25 weeks is really long. And I don't think, I feel like I'm on a roll for inappropriate behavior as a professor. I don't think that there's somebody who's a patient who goes, oh, that's right, I was a hooker about 2 months ago. I had forgotten. When you think that maybe they have hepatitis B. So it's got a really long incubation period. As far as signs and symptoms, they actually feel better. They are not as sick.
So one question I had was,
Yes.
did you just say that hepatitis B is only transmitted in 2 ways, needles and sexual intercourse, right?
I
So if someone has infected, like say you're touching something that's infected with hepatitis B, then how would you
You have to have
contract that?
remarkably bad luck.
Okay.
So you would have to have an open wound.
I didn't understand that.
Good morning, Alexa.
Yeah, I don't know how.
So Alexa didn't understand it, but Dr. Bowers understands your question. She'll win over the robots. So you'd have to have remarkably bad luck.
Okay,
You would have to have an open wound.
I see.
You would have to take some hepatitis B blood and smear it in there. You would have to take somebody who has active, let's see, awesome, that's about it. You would have to have open wounds on your genital and be someplace where somebody just ejaculated or something. It would be really very complicated.
Thank you.
Jessica.
And I didn't quite hear what you said about that 1 tablespoon. You can
So
dilute
if
it
you
in
take a
blood.
tablespoon of, so let's say we have a patient who has active hep B. We take a tablespoon of their blood, just a very little bit, a couple mils of blood, dilute it in a railroad cart of saline. It's a big dilution factor. That saline is highly infectious. It's a highly infectious virus. It's pretty tricky. It's not as tricky as HIV. HIV is a tricky virus because it mutates in 20 minutes or so. Anything else? Signs and symptoms, that's where I was. Signs and symptoms are the same as Hep A, only they feel better. Hepatitis A patients are really sick. In that prodrome phase, they just feel really bad. Hep B people don't feel as bad. They get the same 3 symptoms, right? Prodrome and icteric and recovery. They live. But in the prodrome phase, they don't feel as bad. Their tricky thing is the anticteric phase. If you have someone who has B, which is very contagious, and they don't feel that bad and they don't look jaundiced, you can see how you can spread this pretty effectively through population because you don't know that you have hep B, you're spreading it. So it's tricky that way. So they feel better. Their initial lab findings are the same with the AST and ALT, blah, blah, blah. That's all identical to hepatitis A. But their serological testing is a little different and a little more ugly. You have in your notes something that looks sort of like this, and it's probably back where those pictures are. And you also have the words. So let me walk you through this. There are 3 antigens, and then there's 3 corresponding antibodies for a total of 6. So you think, I don't like this doctor stuff anymore. Good news, 3 of you don't. Okay, here we go. The 3 antigens are hepatitis B surface antigen. This is the outside of the virus. And there's a hepatitis B core antigen, which is obviously the core of the virus. And then there's a hepatitis B antigen, which is also in the core of the virus. Back up. 3 antigens: surface antigen, core antigen, E antigen, which is also in the core. Then there's 3 corresponding antibodies. So there's a hepatitis B surface antibody, a hepatitis B core antibody, and a hepatitis B E antibody. Okay. So that's like point little 1 here. So let's start with the first thing is hepatitis B surface antigen. Hepatitis B surface antigen is the first serological test to become abnormal and Hep B. After you're infected, the surface antigen goes up pretty quickly, but it also comes back down pretty quickly. If you look at this picture, which would look a lot like your picture, this is the color. This is your hepatitis B surface antigen. So here's your post-exposure weeks, here's time 0. So shortly after being infected, you'll be able to detect hepatitis B surface antigen. It's the first thing to go up. If you're detecting this, your patient has an active hepatitis B viral infection. That's kind of the claim to fame for the hepatitis B surface antigen. So it's the first serological test to come abnormal. If you detect it, they have hepatitis B. Pretty quick The second one is hepatitis B surface antibody. So when you or your patient gets infected with E, that's the antigen, your immune system will mount a response and make an antibody. So when you get infected with Hep B, your immune system is going to make antibody. Hepatitis B surface antibody is the antibody with the surface antigen. And in this picture, that's this right here. That's your hepatitis B surface antibody. Okay. So antigen, surface antigen, first to be detected if you have it, you have hepatitis B. As you're getting better, your body will make a surface antibody. And there's three, so that's two of them. The other one that's important is the hepatitis B core antibody. So skip one, that should be the next thing. The core antibody is the antibody that the patient will make to the core antigen. And the core antibody, you can measure IgG and IgM to the core antibody, same thing. IgM for acute, IgG for chronic. So there's this thing called the core window. That's diagram-wise this thing right here. The core window refers to the antigen went bye-bye. The antibody hasn't arrived on the scene. The core window says the only thing that you can measure that says that this person serologically has hepatitis B is the core antibodies. And that's this little dotted line here. That's your core antibody. That's the core window. So surface antigen, they have the hepatitis B infection right now. Surface antibody comes later, confers lifelong immunity for hepatitis B. Core window is when antigen went away, antibody hasn't come, and it's the only serological test that we can measure is the core antibody. It's actually way more complicated than that, but this works really well. Does that make sense to you guys?
Mhm.
The serology. Okay. Great. The next thing is to interpret some of this. So, I'll do it in order in your notes. The first, so it says interpretation of hepatitis B virus serological testing. So, the antigen is positive, core antibody negative. What does that person have?
Acute. Heal.
They have acute hepatitis B viral infection. Okay. Early stage, because they have a multiple immune response. Make sense to you? Second one, we have the surface antigen is positive, core antibody is positive, surface antibody negative. What's that person have?
Acute.
So they still have an active infection because antigen positive just means active infection. But they started to mount a response. So it's a acute infection. It's a clinical stage. Far enough into it that there are signs and symptoms. And the surface antibody hasn't arrived yet. There are people that are chronic carriers of B, which are really difficult to deal with. They never develop a good surface antibody immune response to hepatitis B. They just go around infecting. Very scary. Third one, antigen is negative. Core antibody positive. Surface antibody negative. What's this?
I don't know.
Core window. Core window. The last one is antigen negative. Core antibody positive. And surface antibody positive.
previous infection?
So it's an acute infection? Can't be because the surface antigen is gone. So this is either somebody who's in late convalescence from an infection. So their body has launched an immune response down the road a little bit here. Or an old infection, because IgGs, okay? IgGs are forever. So an IgG, once you mount that infection, you will always have that IgG antibody forever. You would have to tell the difference between late convalescence or an old infection history would help you. And you could also do titers to see if that IgG is going up. Great. The prognosis of B is similar to A, however, it carries a mortality rate of 1 to 3% or so, which is pretty high for an infection. So it's not something to sneeze at. It's a pretty bad infection. Okay, chronic hepatitis has a definition. It's hepatitis that's gone on for at least 6 months. And chronic hepatitis is further divided into chronic benign hepatitis and chronic aggressive hepatitis. So chronic persistent hepatitis or chronic benign hepatitis follows typical hepatitis, and patients have no symptoms. They have persistently high transaminases, sometimes for years. And every time you measure your blood, you see that AST and ALT are elevated. Usually have no symptoms. They might have vague symptoms. They don't for anything. Other liver function tests are just fine. You just see AST and ALT are high. You just wonder why that is. And that's chronic persistent or chronic benign hepatitis. The other choice is chronic active hepatitis or chronic aggressive hepatitis. Often abbreviated CAH, chronic active hepatitis, chronic aggressive hepatitis. Same thing. Follows typical hepatitis, usually, not always, but causes typical hepatitis. They have some non-specific symptoms. They have some symptoms of chronic liver disease, spider nevi, stuff like that. And they have a lab, which really helps you know that you have chronic active hepatitis, and it's anti-smooth muscle antibodies. People who have chronic active hepatitis, a goodly percent of them have anti-smooth muscle antibodies. It's a great test. I think somebody has chronic active hepatitis. Yep.
I hear a lot chronic in 6 months go hand in hand. Is that because that's?
You mean like for all diseases?
Yeah, it seems like that. Is that truly the case, or some diseases have different timelines for when it becomes chronic?
Oh, for when they say it's chronic?
Right.
I think that's probably just from a doctor nomenclature kind of thing that acute to me, acute is 3 months, 0 to 6. Subacute is 3 to 6. 6 on 8, whatever, considered chronic. Can't think of any time that's acute for more than 6 months. That seems like too bad long. So, but I don't know that certainly from the orthopedics, stuff like that. That's really classic. It's how soft tissue heals. Rachel.
I was just wondering for the chronic hepatitis, when we were looking at the antigens, are they going to be that acute one, or are they going to have symptoms, or what are we going to see if they can't make the antibody? Like, what are their symptoms?
The carriers?
The carriers, yeah.
Usually none.
None.
It's more of an epidemiology thing, like they have to work backwards in time to find these carriers. They typically don't have a lot of cases. They might, because they don't mount an immune response that seems to work, they can eventually get into things like chronic liver disease. It's like everything. You can have human beings that carry strep. They don't have strep throat. Dogs can carry strep. And you see a family, they keep getting strep throat. Where are you getting this from? It's actually either from one of the members in the household know why. Some people are like, Great. Next is alcoholic liver disease. Alcoholic liver disease is also called alcoholic hepatitis. As I mentioned late yesterday, it's on this continuum of when you're ruining your liver with alcohol, it will eventually end up with cirrhosis if you don't stop drinking alcohol. It's a continuum. So alcoholic hepatitis is a variety of pathological changes in the liver and it really throughout your whole body due to alcohol. Alcoholic hepatitis is considered a major preventable health problem. It's multifactorial in how it affects the body. They used to say, and I bet your notes maybe you still say, that alcoholic hepatitis is usually seen in your 30s to 40s. And I never have thought that I would stand in front of a group of a few people saying, yeah, it's actually in your 20s now. You can see alcoholic hepatitis in your 20s to 30s. It's because people are drinking at a younger age, overdrinking at a younger age. It takes about 10 years to wreck a liver with alcohol. That's an about. It can take longer, it can take less time. It's directly related to how much you ingest and how long for you lose a liver. But it takes about 10 years. So it's very sad, I think. Very sad that something used to be seen in the 30s and 40s has been done a whole decade because children, in the true sense of the word children, are drinking alcohol. They do lots of survey research that shows kids as young as 3rd grade drinking alcohol, which is very sad. So, when you have alcoholic hepatitis, your signs and symptoms are broken into two kind of major disease categories. You have an abrupt onset of fever, jaundice, ascites, edema, and then you start seeing chronic symptoms of liver disease, vascular spiders, bleeding phenomenon, stuff like that. And obviously a history of alcohol abuse. Lab-wise, first of all, it looks just like cirrhosis, except for one thing. That makes sense, right? So alcoholic hepatitis is here, and cirrhosis is here. It would make sense that the labs would look pretty much the same, and they do. The one exception is the white count. The white count is increased in persons with alcoholic hepatitis. The white count is normal in somebody with cirrhosis. And that kind of makes sense also to your head, I think, in that alcoholic hepatitis are actively inflaming those liver cells and killing those liver cells. The white count goes up to try to save the day. When you're in cirrhosis land, those hepatocytes have been replaced with scar tissue. Scar tissue is not inflammatory in nature, and so the white count is perfectly normal in cirrhosis. So some specifics here. The white count is kind of mildly increased, maybe 10 to 20,000, something like that. The anemia is typically all persons who have alcoholic hepatitis, and you get to choose everything. So it can be hypochromic microcytic due to iron deficiency from throwing up blood. It's an esophageal varices, throwing up too hard. It can be macrocytic because you can get B12 and folic acid. If you remember, folic acid is stored for maybe just a couple months in the liver, and it becomes depleted quite quickly. B12 though sticks around for a long time, maybe 5-6 years. So you can get a macrocytic thing. You can get a normochromic neurocytic, although that looks like a W. And that's because alcohol suppresses the bone marrow. My understanding from alcohol has effects on every cell in the body. It's not just limited to the liver. And that alcohol, too much alcohol will decrease your bone marrow, and that's where the normochromic neurocytic comes from. So they all get anemia. They just get to pick which one for whatever reason. AST and ALT, good for death of hepatocytes. So So AST and ALT would be increased. ALT is traditionally more than AST, usually chronic. Alkaline phosphatase might go up, doesn't go up spectacularly. It's not cholestasis. The whole bilirubin show, because of the hepatocytes, you're back into that middle picture where the liver is affected with hepatitis. You start to get a reversed AG ratio because it's chronic liver disease. You expect that. ProTime, same thing, chronic liver disease. GGT, great test. Great test for detecting alcoholic liver disease early. It's a great test for detecting alcohol abuse early. It will show casual use by usually doubling itself. If you have a GGT that's doubled, the easiest thing is for the patient to refrain from alcohol for about 72 hours, remeasure it should go back down to normal. You can't hide from GGT. You can't study for a GGT test. Chronic alcohol use, you're not going to undo the GGT. You'll be able to find it that way. I think we've talked about the CAGE questionnaire, right?
Mhm.
Yeah. And mean cell volume. So mean cell volume. So if you're wanting to know about alcohol, mean cell volume goes up, GGT goes up, CAGE questionnaire comes positive. Hard to put which one of those would be first. They kind of all run in a row together. CAGE questionnaire is pretty easy to administer to a person, and those MCV and GGT pretty common for early alcohol use. Treatment, mentioned this yesterday, super easy to take, not easy to do. But the treatment is to stop drinking alcohol. Much of it's reversible until you get to cirrhosis. When you get to cirrhosis, you don't get to go back because the architecture of the liver has actually changed. Care for specific problems, very often nutritional deficiencies. It's not a hard and fast rule, but if you are consuming most of your kilocalories from alcohol, it's not really rich in vitamins and minerals and protein and stuff like that. So there are often a lot of nutritional problems that need to be dealt with.
Question?
Yeah.
Back on section B for number 8, are you talking about increased GGT as in it's gonna go up further than ALP or just?
I don't know where you are. How far back are you going?
Where it says increased, GGT, the
Yep.
last one on that,
Oh, yeah, gotcha, yep.
you mean that's gonna go up as in higher?
Disproportionately. Yep.
Disproportionate, okay.
Yep. So next Tuesday, sure, we're gonna do a bunch of cases and you will see this over and over and over again, where you're gonna see